let's get started here. I'm sure more people will be rolling in live. And then as a reminder, once we're done here, we'll get the recording edited up. Um, so it's nice and crisp for you guys. And then we'll send it out this evening. You'll have that link sent to your email. So keep an eye out for it. Sometimes things with links go to spam. So if you don't see it come through your inbox this evening, just check your spam. But we appreciate you all joining us, especially live. For those of you who are on here live, make sure to ask questions. We want this to be interactive. I'll be monitoring the questions as they come through, and we'll continue to try to do our best to answer them as we go. But for those of you who are new to IKN here, my name is Dr. Kyle Paxton, and then we have Dr. Ryan Foley. We're both the co-founders of IKN, and we'll take you through this hip case discussion today. We're going to try to do more of these this year. The response was really strong to this. We had a lot of people registering, whether live or for the recording. So we're going to try to give you more of these. I think it's just a good opportunity to not just talk through our framework and exercises, et cetera, but give you some real world scenarios that hopefully will help you apply it. And even without taking, any of our courses, hopefully you take some things away today that you can try to apply in clinic or with your clients. So I'll pass it over to Dr. Ryan here, and he'll take it and dive in.
Perfect. Thanks very much, Kyle. And like Kyle said, guys, thanks very much for joining. I know different parts of the world, it's the middle of the day, so not everybody will be able to join live. But for those of you that are able to join live, thanks very much for sharing your time with us. Just to give you a very quick insight into what to expect from this webinar, I'll just jump through the slides very quickly here. So we're going to go through two different case scenarios first, really kind of highlight the differences between these two individuals, and then use those two cases as context to guide further discussion across the rest of the webinar. And then, of course, go into some of the details surrounding progressions, regressions, lateralizations, how we are organizing the rehab process for these individuals. We'll talk about some of the classification frameworks that we use when measuring range of motion and force production. We'll talk about the difference between chasing pain relief and chasing capacity. These are two different things, but they are important when we have individuals come to see us with different goals. Those clients that come in and they say, I just want some relief from this pain, versus clients that, for example, may have had experiences with other therapists, practitioners in the past, and they're sick of just getting temporary relief, and they actually want a plan. Those are two different scenarios there, and so the initial session with those two different individuals will look very, very different. Because if you try to build a long-term plan for someone who actually just wants pain relief, you're probably not going to see them the second time. And of course, if you try to get pain relief, quick pain relief in someone that actually wants a plan of action, then you're also probably not going to see them a second time. Okay, and then we'll just go into some other conceptual things regarding how we assess, how we rehab, some range of motion assessments, some more muscular contractile bias assessments, talking about other conceptual things, and then we'll go into the progressions, regressions, and other strategies regarding these two case scenarios. So just wanted to give you kind of a brief insight into what's coming. So just a heads up before we actually get into the webinar, the next cohort of Online Level 1 is coming at the end of February. Sign up starts February 9th, but it begins February 27th. So if any of this information today resonates with you, if you'd like to go deeper into a lot of the assessment, rehab, progressions, regressions, lots of the conceptual things behind our approach, be sure to check that out. This is a list of the modules. We go deep into the conceptual stuff, into the lower limb assessment, rehab, upper limb assessment and rehab, into the spine, and then into some of the head, neck, and TMJ structures as well. So let's begin with these two case scenarios. So case scenario number one, we have a 50-year-old runner with an insidious onset of right posterior lateral hip pain. The onset was 3 months ago. So again, it's going on for, it's not, I wouldn't say acute here, but it is interfering with the individual's function. It came on after adding hill repeats to his training plan. Okay, so it is important to note there that there is a clear mechanism of, we can't necessarily say injury, but a mechanism of onset. Some other questions that we can ask to really understand, was there any real injury that took place there? Was, was there any bruising? Was there a pop that the individual felt? Was the pain there in the moment? Or did the pain show up the next day or later that night? Sometimes when pain doesn't really show up in the moment, you're unlikely to be dealing with an actual injury or damage to the tissues. But if it showed up later on that night or the next day, you likely experience some kind of overload. Okay, now an overload doesn't necessarily mean something was damaged, but an overload just means you exceeded what that tissue could tolerate. And then, of course, the system reacts by protecting, sending pain, sensitizing the structures around that area, which you experience as, again, pain and discomfort. Going deeper into the assessment process here, we do want to, in many situations, get an understanding of the likely tissue source of symptoms, okay? So when someone says to you they experience a dull ache at the posterior greater trochanter through those muscular tissues, a dull ache would be more indicative of maybe more of a soft tissue, muscular overload, compared to like a pinching sensation or a sharp zapping sensation. Because I do think it's important, and this is something that we do go deeper into in our courses. We want to know what tissue is likely overloaded. Is the soft tissue, muscular tissues, did they experience the overload? Is there some sensitivity more around the joint surface, the labrum, for example? Those structures, have they become overloaded? Is there some overload to a neural structure, for example? That will influence how we initiate the loading process. Because of course, if you have a joint surface that is very irritable and sensitive, I think you should be a bit more cautious with how you begin the loading process compared to a muscular tissue. If a nerve structure, for example, is very sensitive, of course, one of the most sensitive structures in the body, then we need to be more cautious with how we begin the loading process. So the location and quality there, dull ache posterior to the greater trochanter, that slightly refers into the lateral thigh. Again, aggravating tasks here, hills, increasing speed on the flat, and transitioning from sitting to standing. Just feels stiff, but after a couple of steps, it feels like things loosen out. So when we're thinking of the mechanism of onset there, the onset of pain, and connecting that to the aggravating tasks, hills. When you're running hills compared to like a jog on the flat, for example, you're going to shift more demand into the proximal tissues, into the hip structures. As you're jogging at a leisurely pace on the flat, you're not going to experience a lot of demand into the proximal structures around the hip. There's going to be much more demand around the foot and the ankle. And that's why it makes sense that what aggravates this individual is when he increases the speed on the flat. So as you increase the speed, you shift that workload from more the distal structures around the ankle and the knee to more the proximal structures. So as we're gathering this information here, we are considering that, okay, there's likely just more of a muscular overload, a soft tissue overload to the tissues around the hip, the posterior lateral hip, into the glute, the hip extensors, for example. Then we want to dig into previous injuries and pain experiences, because those two things are not the same. Okay, because sometimes when you ask a client about past injuries, they think about things like broken bones, real, sometimes traumatic experiences that have sidelined them for a long period of time. But one of the reasons we want to ask that question is because it gives us an insight into what structures are potentially still experiencing a reduction in tolerance to load, because that reduction in tolerance to load at a certain structure may influence the demand on another structure. So, for example, in this individual's experience, there was some right meniscal surgery in the past and some intermittent back discomfort. So, of course, with the meniscal surgery, of course, the surgical process there, we want to go into deeper detail as to, what was he experiencing beforehand? What was the rehab like post-surgery? But we have to, again, step back and consider there, well, maybe the knee and the tissues surrounding the knee are still experiencing a reduction in tolerance to load. And might that, for example, shift more demand into the hip and then maybe give the hip an awful lot more to do? And might that contribute to that overload at the hip? Because then when you're thinking about, for example, how to increase the tolerance to load at the hip, if you have a knee that's doing very little and the hip, for example, is doing an awful lot, then conceptually, would you increase the tolerance at the hip by just getting the hip stronger? Maybe not, right? It may be a case where you could say, okay, if I just get the hip much stronger, maybe it can tolerate the weakness or the fact that the knee is doing less. But that's still not a good outcome, I think. I think we wanted to increase the tolerance to load at all structures. So that may be, and it was, an important component of this individual's case. And the same with the intermittent back discomfort. Again, no real injury per se, but just intermittent discomfort. But again, that intermittent discomfort is important information because that will, again, hopefully allow us to become more curious as to what's available from a range of motion perspective, what's available from a force production perspective around the lumbar spine. And of course, because you have a pelvis that is interacting with the femur to create the hip, and you have a pelvis that's interacting with the lumbar vertebrae to create the lumbar spine, they share a common bone, the pelvis. So it is going to have an influence over what's happening at the hip. Previous treatment and rehab. This client was seeing a previous therapist before me, was doing an awful lot of hamstring strengthening and glute stretching strategies. And I'll tell you why. This individual, if we go down to the objective measures, and we will go deeper into these objective measures and use those to guide the rehab in just a few moments. But one of the big things that we noticed in this individual was when he engaged in a forward bending motion, a toe touch, there was a significant loss of lumbar flexion range of motion. And so with a limitation in lumbar flexion range of motion, you're going to experience you're going to express also a reduction in the ability to posteriorly rotate your pelvis, okay? And what the previous therapist did was thought that, okay, what muscles will posteriorly rotate the pelvis? Well, the proximal hamstrings will help to posteriorly rotate the pelvis, okay? But also the glutes need to be able to handle forces to posteriorly rotate the pelvis as well. And the mistake that I feel was made here was that there was an assumption in this individual's assessment that the glutes were overworking because they were experiencing the overload, the sensitivity. And so there was a lot of glute stretching done and more hamstring strengthening. But when I assessed the hip actually had very good range of motion from a standpoint of the muscular tissues at the posterior lateral hip. The piriformis, for example, was able to experience a lot of length. So the posterior lateral hip really didn't need a lot of length. And that was influencing then how the pelvis was actually behaving. So one of the key things that we need to do here was actually load the glutes with more of a posterior rotation at the pelvis, but not with your just general, supine bridge variations, with some other kind of key focused strategies as well. So quickly just moving into the objective measures here, we had limited and non-painful toe touch. We'll talk about those classification kind of frameworks in just a moment as well. So all that means is that the range of motion was limited and it was associated with pain. Okay, and of course it was associated with no pain, sorry. So limited and non-painful toe touch, poor posterior pelvic tilt, limited and painful supine hip flexion range of motion. But we'll talk about why that was, because this client actually had a lot of anterior pelvic tilt. And so as we were bringing the femur through that range of motion to close the angle in front of the hip to experience hip flexion, that femoral head was butting up against the pelvis too soon and causing the individual to experience some sensitivity through the anterior hip and through the posterior lateral hip during that assessment. And limited and painful hip internal rotation, weak and painful glutes, and from a force production standpoint, but non-painful quads. So weak and non-painful glutes, hip extension, weak and non-painful quadricep contraction, okay? So weak and painful glutes, weak and non-painful quads. So this is essentially what it looks like here when we go through the objective classification. We'll talk about why we define things or classify things in that way, from a limited and non-painful standpoint, a within normal limits, a non-painful standpoint, a limited and painful standpoint. These allow us to kind of step back and consider, okay, well, what is available, what is unavailable here? What's painful, what's non-painful? Because if you have a range of motion, for example, that is painful, and the range of motion is being limited by a painful restriction, a painful barrier, then you don't know if that individual actually has access to that range of motion, which means that you are you're engaging in a very different process to try and expand that range of motion compared to trying to influence a range of motion that is limited and non-painful. Then we can be a little bit less cautious, a little bit less kind of, we have to kind of almost probe and adjust things when we're working with pain. But when we're working with a limitation with no pain, then we can push a bit more. I wouldn't say aggressively, but we just don't have to be as cautious. We'll again talk about why that's important to consider as well. And the client's goal was to return to running pain-free. Briefly look at case number 2. So we have a 35-year-old ex-soccer player here with left groin and posterior hip pain. Had a CAM surgery 3 years ago, which is again a surgical process on the femoral head to clean things up and reduce that irritation within the hip joint. It flared up 2 months ago after returning to small-sided soccer. So what this individual did was some kind of general strengthening, more gym-based strategies, more kind of slower, heavier, contractile type strategies, more so focusing on increasing strength and endurance and force production in those 3 years, then went back to play small-sided soccer and flared things up after 2 months. And this client had actually quite limited range of motion around the hip because no real focus was put into restoring the tolerance to experience range of motion around the hip. And then, of course, once you establish that range of motion, then we can layer on the contractile strategies on top of that, and then we can layer on some more acceleration, speed-based strategies on top of that as well. But just moving into the aggravating tasks, deep hip flexion strategies, sitting in a car, experience that discomfort in the left groin and posterior hip, stiffness transitioning to standing after rest, and change of direction. That was really the aggravating feature during small-sided soccer, was changing direction, where it would require that pelvis to rotate over top of that femoral head an awful lot more. Previous injuries and pain experiences, again, of course, the CAM surgery 3 years ago. Why that's important is because we know there was some trauma experienced at the hip. And so then we have to step back and consider, well, have we actually restored the tolerance to load around the hip joint? Compared to this situation here, case number 1, where there was no real history around the hip joint. There was a history at the knee, a history at the low back. And so we are considering that, okay, well, maybe there doesn't have to be any direct work done on the hip in case number 1. We're not saying that that's the way it's going to be, or that's what happened, but we can step back and say, well, okay, maybe the low back is not doing enough, maybe the knee is not doing enough, and maybe the hip is just experiencing an awful lot of load as a result, and the way to increase that tolerance is to get the low back to do more, get the knee to do more, okay? But it doesn't mean that's what actually happens. But at this point in time of the assessment process, those are the kind of things that we could be thinking about. Compare that to case number 2, where no history at the knee, no history at the low back, no history even further distally in the foot or ankle, but a history at the hip itself. That's when I would be really considering the local tolerance to load at the hip joint, not just tolerance to contraction, but tolerance to range of motion as well. Previous treatment and rehab consisted of general hip strengthening strategies post-rehab, but again, more strengthening force production biased. We'll talk about the importance of that as well, because there was no real range of motion focus. There was no real more kind of acceleration bias strategies done to allow the muscular tissues around the hip to experience load and tolerate load at higher speeds when we're changing the momentum in shorter time frames, in shorter, smaller time windows, where you're going to experience a bigger spike in force at the hip at higher speeds. Again, think of that force equals mass times acceleration equation. To increase the force value, you can increase the mass, or you can increase the acceleration value. Okay, when you increase the acceleration demand on a structure, you can increase the force value. Okay, so it's going to put more force on the hip when you add more velocity acceleration demands. Objective measures there, different in some ways to case number 1. We had limited and non-painful toe touch, but the way it was limited was very different here, because this individual had poor anterior pelvic tilt. So it was unable to actually rotate the pelvis over top the femur to allow the individual to get further through that range of motion, compared to individual number one, where the client struggles to posteriorly pelvic tilt. Okay, so a very different scenario, because in case number one, if we can't posteriorly tilt, we can't allow for that range of motion to be expressed at the lumbar spine into flexion. Whereas in this individual here, this individual was experiencing or demonstrating more lumbar flexion. So was experiencing a lot more posterior pelvic tilt and was struggling to get that pelvis to rotate over top the femur. I'll show you what that looks like in just a moment as well. A limited and painful supine hip flexion, limited and painful hip internal rotation, limited and non-painful lateral pelvic translation, which we did in standing and in a quadruped position, weak and painful hip adduction, force production, which was 6 out of 10, and then weak and non-painful glutes, hip extensors from a force production standpoint. We're going to talk about what those assessments look like. But just to briefly discuss here, using specifically case number one, how we are objectively classifying these objective measures. So again, if you look at standing flexion here for case number one, it was limited and non-painful. So limited lumbar flexion range of motion, fingers to mid-shins. But again, this client struggled to express a posterior pelvic tilt. So we could say, okay, it's limited and non-painful. So when I engage in a process of trying to expand that lumbar flexion range of motion, because it's not painful, I can be a little bit more, again, I don't want to use the term aggressive, but I don't have to be as cautious when I'm trying to expand that. Because pain is not getting in the way, it's likely that that individual just does not have access to lumbar flexion range of motion. Compared to hip flexion range of motion, which was limited and painful. So if I want to engage in a process of expanding hip flexion range of motion, I need to be much more cautious because it's painful. So I'm not just going to shove the client in and be aggressive with trying to bring that femur back over top of the, or over relative to the pelvis, because it's painful. I don't want to flare the client up. And I can just tell you right now that when you're dealing with individuals that have a lot of limitations around a local joint region, let's say, of course, the hip in this scenario, and let's say you have some directions that are limited and painful, some directions that are limited and non-painful. In general, you may want to consider exposing or expanding the directions that are limited and non-painful first, because that just increases the space, the total space around that hip, and may allow the individual to tolerate. So I think someone's connecting to audio there. It may allow the individual to tolerate the strategies to expose the limited and painful directions. Okay, I'll give you a quick example. A client I had today who had limited and painful lumbar flexion, limited and non-painful side bending, limited and non-painful rotation, and limited and non-painful extension. So really stuck, really contracted, very stiff around the lumbar region. Okay, because this client was actually engaging in a lot of core stability strategies with the previous therapist. In that scenario, there's many different directions that are limited there. So if lumbar flexion is limited and painful, we can consider that if other directions are limited as well, that the reason why lumbar flexion might be painful is because the individual is being constrained into that direction, meaning that may be the only option they have to try and move the spine. They're engaging in a lot of lumbar flexion. It's being sensitized. So how do I increase the tolerance or decrease the sensitivity initially? I can do that by expanding the other directions, by expanding side flexion, by expanding rotation. And what that does is it increases the total surface area around the lumbar spine to allow you to spread range of motion and spread load into more directions. And that may allow you to expand motion into the previously limited and painful direction even more so. Okay. One thing that this client demonstrated as well, we won't go through all of this in significant detail, but was within normal limits. So that would describe that the range of motion is within normal limits. It's full. They have the available range, but it's painful. And that was with actually the seated figure 4 and with the quadruped pelvic shift. So that should be within normal limits and painful as well. So in a seated figure 4, where generally you're getting an insight into how well the hip can flex, externally rotate, but you're also getting an insight into how well that piriformis can tolerate stretch as well. And this client was able to get into that position very well. We'll show you what it looks like when clients can't do that. But it was painful. And I can tell you now that this individual had a lot of length through the posterior lateral hip, but was struggling to actually get the pelvis into a posteriorly rotated position because the lumbar spine was limited in flexion and allow for that glute to handle forces in more of a mid-range position. And you can conceptualize there that maybe this is what led to an overload, because if that glute is always under length, because we're very anteriorly tilted and we don't have the ability to let that pelvis move, then the posterior lateral hip is going to experience an awful lot more tension in a lengthened position. And what this previous therapist was doing was trying to lengthen the glutes even more so, which they didn't require more length, okay? And then from a force production standpoint, so when we talk about movement at IKN and when we use movement as an intervention, we need to separate movement into range of motion features and into force production features, okay? We really try to simplify this because this allows us to gather these clear variables. So you'll see here that we're describing the test being done, the status of the left and right. Is it, you can have range of motion. Range of motion can be one of 4 things. It can be limited and painful, limited and non-painful, within normal limits and non-painful, or within normal limits and painful. Okay, 4 options. And of course, you have to go deeper into describing what about that was limited, what about that was painful, what's the intensity of the pain, the location of the pain, and those kinds of things, right? But when we look at things like this, and it just allows us to step back and get a nice big picture of, okay, what's available, what's unavailable, what's limited by actual capacity, meaning they can't actually do it, and what's limited by pain. Same thing from a force production perspective. The contraction of muscular tissues, and we generally look at joint actions first, meaning when you contract muscles, yes, you have many muscles in the body, individual muscles that all do similar things. So when we look at hip extension, for example, we know there's many muscles that will contribute to hip extension. But when we're looking at the joint action, we're just looking at the directional motion of the hip and how it's contracting and generating force into hip extension. And what we'll typically do is we look at that in a shortened length and a mid-range lengthened length as well, to see how well it can tolerate contraction at different lengths. Because when you contract something in a shortened length, it's going to experience less tension than it would in a shortened, in a lengthened position. Okay, so a single leg bridge in a supine position was strong and non-painful on the left, weak and painful on the right. Split stance hinge and hover, which is a strategy we'll show you in just a second, to get more length and load into the hip extensors, was weak and non-painful on the left and weak and non-painful on the right. And split stance quad hover was weak and non-painful on the left and weak and non-painful on the right. So a little bit of deconditioning across both limbs in this scenario here. And so this is important to know because when we have that history of a right meniscal surgery, we want to then say, okay, well, how are the quads generating forces? So we want to use a strategy, an assessment strategy, to see how much load the quads can tolerate. And in this case, the quads were weak, but they weren't expressing much pain, meaning pain wasn't getting in the way there. I can really push on with quadriceps strengthening strategies in this case without being worried about flaring things up, okay? So just some brief conceptual things before we get into the actual rehab pathways for each individual. In general, the process of making decisions from a rehab standpoint involves understanding the individual story. Okay, we gather subjective information, we gather objective information through a movement assessment, and those 2 things gives us the ability to determine the likely tissue source. It gives us the ability to, again, gather those clear variables as to what's available, what's unavailable. Okay, that is one of the biggest reasons why we try to simplify things into the range of motion available or unavailable and into the force production that is available and unavailable from a joint action standpoint first, and then we can go deeper into muscle action if we need to, okay? Because when we gather those clear variables, number one, they're much easier to measure and observe. It's much easier for me to say, okay, that range of motion is there or it's not. It's painful or it's not. That they have the ability to generate force through those tissues or they do not. It's painful or it's not. That's clear for me, which means I can go back and reassess things much easier to guide progress in that individual's case. If I start using terms like, okay, they don't have the stability at that joint. Well, number one, how do you define stability? And what are you actually looking at to tell you that there is less stability there? Because it's messy, and we all have to accept that it's messy. It's very hard to come back and reassess things and say, okay, that's more stable, or it's not more stable, okay? Because at the end of the day, stability is an umbrella term to describe some range of motion or some position and force production, because that's what underlies all movement, okay? So we gather the information, we conduct a movement assessment, and we generate a hypothesis as to what is going on there, okay? What is the reason the individual is experiencing pain, okay? Now, one thing that we have to understand here when we are generating a hypothesis or an explanation, because the client will say, well, why am I in pain? Okay, what's wrong here? Okay, well, first they'll typically ask, well, why did it happen? Well, in this scenario, case number one and case number two, it's easy to have that conversation with the client and say, okay, this is why it happened. Sometimes, and many times, you'll have clients that want to know why it happened, but the onset is very unclear. There was a gradual onset, or things came on suddenly during a very innocuous task, and then things gradually increase from there. In those situations, it's harder to determine and pinpoint what actually caused things. But in my opinion, what we have to get better at doing is trying to make sense of why things are perpetuating past a normal point of recovery. Meaning, if this individual here experienced some kind of overload at the hip 3 months ago, then what should naturally happen there? Things should calm down, they should recover, and then the individual should be able to get back to pain-free movement, right? Same thing with this individual. He gets surgery, does the rehab, restores range of motion, restores force production, and then gets back to pain-free movement. So it's not a case of, okay, what caused these things? For me, it's more of a case of what is causing these things to perpetuate, meaning what's happened after the fact and what's keeping you in pain as opposed to what has caused pain in the first place. That's a really important thing that I really tried to get across to my clients, because so many clients are constantly trying to find what caused this, why am I in pain, instead of actually stepping back and breaking things down into what they actually have available, what they don't have available, and seeing, okay, how can I expand my available movement options now to give my system the chance to spread forces and share forces more broadly, so I can avoid irritating the issue and expand other movement options, okay? So those are key things to understand there. And then we have to, of course, do something, right? And when we are, and this is why this at the top here is labeled pain relief versus capacity building. Because if you are engaging in a process of trying to relieve pain and you decide to use intervention, you do that intervention, the client engages in some kind of movement, some kind of activity, and when you look for the response, you only have 3 responses after an intervention, particularly when you're dealing with pain. It's either better, it's the same, or it's worse. You only have those 3 options, okay? So naturally, when you're looking for pain relief, you're hoping that things feel better. But of course, we know that that's not always the case, okay? But if pain relief is the focus, you're looking for things to feel better. Now, why it's important to look at these 3 things here is that when we're engaging in a process of expanding capacity, meaning, for example, if I'm trying to expand lumbar flexion range of motion here, which was limited and non-painful, then when I do something and I try to expand that lumbar flexion and I assess the individual after an intervention, see how they feel. If they tell me they feel the same, I'm completely fine with that, because I'm not actually looking for that to have a dramatic impact on their symptoms. I'm looking to try and expand lumbar flexion range of motion. Now, you could also say that, okay, if the lumbar spine flexes and we get that posterior tilt of the pelvis and we allow for a little bit of sharing of motion into the lumbar spine now, where we're getting length into the lumbar extensors, then maybe that might reduce the irritation at the posterior lateral glute here, okay? But if it doesn't, we're okay with that because we're chasing a capacity. This is why it's very important to look at things differently. Because if I'm just chasing pain relief, then I might just do some more kind of low level things, reduce some muscle activity around the hip, reduce muscle activity around the lumbar spine, some with more manual methods, low stimulation methods, but I'm chasing an improvement. For me, that's complicated because you'd end up getting into a situation where you're doing something, how does that feel? Feels the same. You do something else, how does it feel? Oh, it feels the same. And you get into this kind of awkward kind of situation across the rehab session where you're doing something, you're just chasing random things and hoping the client says it feels better, okay? That's why you have to have that conversation with the clients and be clear on actually what the goals are. Because if you're chasing pain and you're hoping for that better response, when in reality they might not achieve that because this pain has developed from a lack of a capacity, then you don't want to be chasing a better outcome within the session. You don't want to only chase the pain, but you want things to stay the same as you gradually expose things. You're basically trying to ensure you're not flaring the individual up as you start to gradually expand range of motion and force production. Of course, you don't want things to get worse, okay? And if they do get worse, you want to make sure that they settle down very quickly. This is why when you're doing something and you're, thinking that, okay, this might flare the individual up, you don't just throw like 3 sets of 10 on top of them. It's like if you're trying to, buy a couple of desserts, for example, in a bakery, you don't just gobble up all the desserts. You try something first, see how it tastes and say, okay, I want a bit more of that. When it comes to, doing exercises, it's kind of the same thing. You do a little bit, how does that feel? Okay, it feels okay. It feels better. That's even better if it feels better after that. But I just want to make sure it's not worse. So I might do like if it's an isometric hold, I might do like 10, 15 seconds at a low intensity through that muscle and then recheck how they feel. This is your test, intervene, retest process. You don't just throw a lot of load on top of them. Of course, when it comes to understanding their story, we have lots of things that we can consider there. Past injuries, past rehab, aggravating tasks, easing tasks, goal tasks. We need to be, in my opinion, much better at gathering information from the subjective. We'll come back to this if we have a bit of time. But this slide here really reflects how we simplify things at IKN. What we want to do is look at things from a directional standpoint. And this is how I actually describe things to my clients. I want them to have access to multiple options, okay? And because we break things down into, when we look at movements, because we largely use movements to influence someone's pain during movement. And if we break movement down into their simplest components, we have, if I was to define movement now, I would say movement is defined as a muscular contraction through a defined range of motion, okay? So we all know those awful neurological diseases like ALS, where when you lose your muscle contraction ability, you cannot move, right? So if you cannot contract the muscle, you cannot move, okay? And so when the muscle contracts, it pulls on the tendon, it pulls on the bone moves relative to the other bone, and that creates motion at a joint. That's what movement is in a nutshell. And that's really as simple as I think we should be making it when we're trying to make decisions about what kind of movement to give our clients. And I like to break things down into looking at directions, okay? So we're looking at, of course, flexion, extension, forward and backward motion, sideways motion, and rotation, okay? So if someone, for example, doesn't have the flexion range of motion here, I want to expand that direction. I want to make that direction available. So that's what our assessment is. It's looking at what is available, what is unavailable. Because in general, I want to chase things that are unavailable, right? If I go to my doctor and he tells me that I'm lacking in calcium, I don't want an iron supplement. I want a calcium supplement. I want the thing that I'm lacking, because I want to expand that to make that available. The key thing to understand here then is how what does the process look like to make something available? That's the key thing. So if in this scenario here, hip flexion range of motion is limited and painful, some pain at the posterior lateral hip, how do I make that hip flexion available? Do I just force that femur even further? Or do I consider how the lumbar spine is contributing to that? Do I consider how the hip extensors are contributing to that? Maybe by getting the lumbar spine to flex better, or to flex more, so I'm expanding that available range of motion, then that will allow for the pelvis to posteriorly tilt and afford more space for the hip to flex via the femur. And then all of a sudden, something that was limited and painful may become either limited and non-painful, or within normal limits and non-painful. So you've influenced the availability of hip flexion via expanding something else. Okay, so it's the process of expanding what we identify as unavailable, which is, I think, what's most important as practitioners. But we need to understand that that is a process. It's not like, here's the exercise for your hip flexion limitation. It's like, how do we organize things to get you there? And that requires us to step back and look at all of these things together. Okay, look at the whole picture. So let's look at some range of motion assessments within the context of these two cases. Now, these are kind of just giving us some kind of insights into the biomechanical behavior of things. But when we look at the toe touch here in this individual, we'll see here that there's a lot more of a spinal dominant strategy initially here, where the spine is, I would say, rotating forward. Okay, we see the pelvis is not really moving forward. It's the spine. And the individual experiences a limitation there. So we have to ask ourselves, well, what is not rotating forward, looking at it from a directional standpoint? What is not rotating forward and not allowing the individual to go through that full toe touch? What segment is not moving forward? Is it the spine? No, it's the pelvis that is likely not rotating forward. Okay. Of course, we can look at this to say, okay, is it the glutes? Is it the hamstrings? Because both of those will limit the pelvis's ability to rotate forward. But this, we would say that the individual has a lot of lumbar flexion, but maybe a limitation in an anterior pelvic rotation, because that pelvis has to rotate forward over top the femur to allow for the glutes to lengthen, to allow for the hamstrings to lengthen. Okay. So if that's not available, then you're not actually allowing the glutes to lengthen, and you're not allowing the glutes then to actually afford you the ability to spread load across more tissue, more surface area. When muscles lengthen, it allows you to spread force and demand across a bigger surface area. What you'll often see sometimes when you're measuring hip flexion, and this is just more of an active range of motion assessment, is that when we get to something like 90 degrees here, and we're looking at, again, 120 degrees of hip flexion, when I bring that femur to 90 degrees, what you're seeing then is that pelvis begins to rotate posteriorly. And you'll see the other femur lift off if we have some limitation in the hip flexors on the opposing side. So what you're seeing there now is not just femur moving relative to the pelvis, but the femur and the pelvic segment moving backwards as a unit. So a lot of the motion I'm getting there is from the lumbar spine. So one of the things that we'd have to do there then is try to limit that lumbar flexion. One thing that I would do with many clients is get them to put their hands underneath their lumbar spine to reduce that tendency for the lumbar spine to flex. And this is just giving you kind of a quick insight into what that looks like here. So when the femur moves through that motion relative to the pelvis, we see the pelvis rotating in the same direction as the femur. That's what we want to see. We want to see that femur have the ability to get to about 120 degrees. Okay. Now, you're not going to be able to get the thigh to the chest in that scenario. To get someone's thigh towards their chest or towards their belly, you need that pelvis to posteriorly rotate. Okay. But when you're looking at just femur and pelvis motion, you want to limit the motion at the pelvis. And this is what case number 2 is demonstrating, an inability to allow for motion to actually occur at the hip joint, the interaction between the femur and the pelvis. It was the opposite in case number 1. Case number 1, there was a lot of motion at at the femur and pelvis, but the pelvis wasn't moving appropriately to afford more distribution of load around the hip. So the way we organize things was very different. And you'll see that in the rehab strategies once we get to them in a few minutes. I like to look at a lateral translation of the pelvis as well to see how the lateral tissues of the hip are lengthening. So I have the client get a little bit of a bend in their knees, and then I'll have them drive the pelvis laterally to see subjectively what they experience there. And then sometimes you'll see just a more of a limitation in getting that pelvis to laterally translate in another direction, because we have to understand that getting that pelvis to translate laterally will allow for a lengthening across the lateral hip, which is important, and it's a component of getting length into your glutes. So what you're seeing there is this type of thing here, where because you imagine this is the focus here, the right limb, foot's on the ground, fixated on the ground. As we translate the pelvis laterally, we're going to be opening the space here, these tissues on the outside of the hip. And I look at this actually in a quadruped position as well, where the hips are flexed. So looking at the seated figure 4, I like to look at this as just a general insight into how well the piriformis can lengthen. You'll also see this limited in individuals that have true bony limitations, arthritic limitations in the hip as well. But this is what you'll often see in many clients that are limited. As that hip goes into flexion, it's going to drag the pelvis into a posterior rotation. You're going to see a lot of flexion at the spine. And you're also going to see an inability to externally rotate the femur, because we want to get that knee down. So if an individual was demonstrating this, the other day I had an individual where older individual suspected kind of, wear and tear, kind of arthritic changes at the hip. Okay, how could I tell, for example, if this limitation is from a more of a muscular limitation or more of a joint specific limitation? What I like to do in that scenario is I like to, again, measure external rotation, internal rotation in a position where the length of the glutes is not being challenged. So I'll get them into a prone position where the glutes are more shortened. And if, for example, I see that there is available internal, external rotation, range of motion from a joint perspective, then I'm more confident that what's limiting this here is actual muscular limitation, soft tissue limitation. So I can be more confident to say, okay, I want to try and expand the muscle lengthening across the posterior lateral hip there. Okay? Because what we are looking for here is something like this, where I can externally rotate, so I can let that knee drop down with more of an anteriorly rotated pelvis to demonstrate I have length through the posterior lateral hip. What's interesting in case number 1 is that this case number 1 had the ability to do this, had the ability to get into this nice tall position, drop the knee down, tibia was parallel to the ground, had a great lengthening ability through the posterior lateral hip, but it was painful. So then the question is, how do I make that non-painful? Do I need to stretch it more? Because this is what people will do. They'll say, okay, this is a test for the lengthening of your piriformis, let's say, some other muscles as well, but it's painful. Does that mean I need to just stretch the piriformis more? No, because it's within normal limits. So then the question is, how do I make that non-painful? Is that not tolerating load now, or that range of motion? Because that's the range of motion that it's stuck in, so to speak, because the pelvis is struggling to posteriorly rotate. Okay, and you can imagine that with those hill repeats and with the individual not able to allow for a bit more of a posterior pelvic tilt during that knee drive and that whipping back, that extension moment at the hip, maybe the muscular tissues at the hip were just overloaded in a lengthened position where they experience more tension, but secondary to a range of motion limitation. So looking at assessments here, again, looking at the internal, external rotation. So internal, external rotation here. I like to do this in a seated position. I just find I get a kind of a cleaner insight into more internal and external rotation. But just to briefly talk about here, because we still have a good few things to get through. I know we're kind of up near the hour here, but this is what always happens with me. With this quadruped variation here, what we're doing here is we're getting an insight into how well the posterior lateral hip here is lengthening. So this looks like a modification of your kind of pigeon pose stretch. I'll get the client into a quadruped position, externally rotate the femur. That will actually drop the greater trochanter down on that lateral side and allow me to get more length into the lateral hip. And then what I'll do is I'll ask the client to sit back slightly and then drive the hip laterally to see how far they can actually laterally translate the pelvis. And what you'll find in clients that have an inability to get length through the posterior lateral hip is it will look something like this. Where they'll sit back, they'll try to drive the hip laterally, but they'll actually do some funky things around the hip. They'll kind of rotate away to get more shortening into the tissues there. They won't be able to keep that pelvis square. Okay. Let's look at some other kind of assessments here briefly, looking at the single leg bridge here. This is one that we did with case number 1. So I'd like to look at that just with a general, hip extension moment first. That was painful for the client initially. But then what I like to do is I like to see how does that feel and how much force can they generate when they posteriorly rotate the pelvis and drive that pelvis through a forward translation. Because then you are, again, bringing the glutes into more of a shortened position. You're challenging how well the glutes can generate force without getting any contribution from the lumbar extensors. Or you're biasing a bit more lumbar flexion as you do that, okay? Now, that doesn't mean that we don't necessarily want the lumbar extensors to contribute to the generation of force. But if the lumbar region is already sensitive, then that can be associated with pain if you do that in more of a lumbar extended position, okay? I don't have any problem with someone generating force via hip extension and getting help from the lumbar extensors. But if it's sensitive, I want to understand, okay, can I make it not sensitive? Can I make it non-painful? Okay, and that can give me information as to what I might need to do then from a rehab perspective. Then I like to use, again, we're showing you more kind of active assessments here, but these are important to understand what is available, what is unavailable. We looked at range of motion, now we're looking at force production. I like to use this kind of elevated kind of split stance hover here. The reason I have that rear knee elevated is that brings me out of deeper hip flexion through this front hip here. The more I elevate this knee here, the more I lift the pelvis, the less degree of hip flexion I'm in. What I like to do then is I like to make sure I keep that shin as vertical as I can. I like to hinge forward if the client can do that. Again, it gives me more information if they can't. Some support in front. I'll have the client drive down through the foot into the ground and then through the heel mainly, and then I'll have them hover the rear knee. And in this position, most of the demand, because you're driving through the heel, I won't go too deep into the biomechanics here, but because we're driving through the heel here, the resultant ground reaction force is driving up through the shin, going through the knee joint, which means the demand on the knee extensors is much less. And it increases the moment arm between that force vector and the hip extensors, okay? So we need to get that shin vertical when we are trying to create force into the glutes via the femur. And very often clients will just really struggle with that, okay? So just to show you that again, we have a bit more of a trunk flexion here, pelvic forward rotation. All I'm showing you here is less forward rotation. But we need to get the nose. So what I like to say to the clients in this situation, get the knee over the ankle and the nose over the toes, just to make sure we get that, that forward motion. What you're seeing here is something different and something that was important in case number 1. Because what we're actually doing here now is we're seeing, okay, can I get into some lumbar flexion? And can I actually allow for a bit more of a posterior pelvic rotation with that load into the glute? Okay, because in this first scenario here, what we're doing is we're seeing, can I actually get length into the glutes? Can I load down to the ground? And can I experience load to the glutes? And how long can I hold that for? And I use that as a kind of a baseline measurement. That's with less hip flexion. And then you're seeing it with hip flexion and lumbar flexion. So this is hip flexion and lumbar flexion. So this was something that was really important for case number 1 to work on, was to allow for the glutes to experience load with a posterior tilt as the lumbar spine stayed relatively flexed. That was honestly the main thing that allowed this client to experience much less symptoms and allowed him to return back to initial activity, and then we just increased the demand on those tissues from there. Looking at some hamstring stuff here, same idea here, some very basic assessments, again, loading through the hamstrings, again, just getting a general shift up of the hips here initially. But I think then also, not just that, is just getting a little bit more of a focused posterior rotation of the pelvis as well. So crushing through the heel, really scooping the pelvis back to see how well those hamstrings can generate force with more lumbar flexion. Again, important if we are considering that, okay, lumbar flexion range of motion is limited, or we're considering that the lumbar extensors are experiencing more demand. Again, that would be more important if you're dealing with a lumbar spine case scenario. But because case number one had some lumbar spine discomfort, and we're thinking that that was connected to the onset of pain, then we wanted to consider that as part of the assessment. Here you're seeing a bit more of a spinal flexion quad bias now. So you'll see now the shin is no longer vertical. Now the shin is more at a forward angle. And if I crush through the heel, it changes the entry point of that force vector. So now the force vector moves in this direction here. So I actually increase the moment arm of the quads here, as long as I'm crushing through the heel. If I wanted to get a bit more focus on the quads, I can bring my trunk more upright, because that would bring more of the mass of my head, arms, and trunk behind my knee and increase the demand on the quads. That's something you're going to see if clients really struggle to get that. They're going to try to extend the lumbar spine. They're going to try and get more demand into the glutes. You'll see that knee shift back. This is what that client demonstrated, case number one as well. This is just a very kind of brief insight here into how we kind of differentiate between the different variables we're expanding. So are we expanding range of motion? When we're expanding range of motion, we separate them into local and coordinated features. When we're trying to expand range of motion locally, we want to ensure that we are constraining all the range of motion to that one joint. When we're expanding range of motion coordinatively, we're getting assistance from other muscular tissues and other joints. This is really helpful when we are, for example, dealing with range of motion that is limited and painful, but we want to try and target that range of motion and expand it. So one of the things we can do is we can get some range of motion into that joint, but we don't necessarily need to get contraction around the local muscles. We can spread the range of motion across more muscular tissues, and it can be a lot more tolerable for the individual. We'll show you a couple of examples of that. And the same idea with muscular contraction. We can either constrain demand into a joint action via local muscular tissues at a joint, or we can spread demand across multiple muscular tissues, okay? Here are some intervention options here. Again, it's important to kind of step back and consider, well, what are the intervention options that I have available to me as a practitioner? First, it begins with creating clear goals. And that's why, again, it's important to have those clear variables. You're either influencing range of motion. And yes, of course, you can go deeper into the understanding of what do you mean by increasing range of motion? What about the range of motion is limited here? Again, in case number one, how do we manipulate the pelvis? How do we manipulate the femur? Is it more limited by muscle activity? Is range of motion, for example, more limited by pain and fear? Maybe the client is fearful of going into that range of motion. Maybe that's what is reducing it. Maybe, again, it's more common in the spine, but maybe an individual is not bending the spine because they were told by a family friend or a doctor that bending the spine is dangerous. And so they are not expressing that range of motion out of fear of damage. How you increase that range of motion then is very different, okay? And so it's important to consider that. So we like to look at like three general intervention categories. You have your active movement, you have your kind of blend of active and passive strategies, and then you have your passive movement strategies. This is what we're looking at today, targeted movement. Now, I'm not saying that you always need to be extremely targeted with your rehab, but I think when we're dealing with more persistent cases, particularly in active individuals, very often they're avoiding tissues. Very often they're not getting range of motion into certain directions, and we need to be more targeted with our interventions. In individuals, for example, that are not as active, we can be more general. We can get some general load into their system and combine that with more targeted strategies. Then we have our blend of active and passive. This for me would be your kind of manual therapy positioning type strategies where you're manually positioning an individual into a position or a range and you're having them contract against you. So it's not just you're passively moving their body, but you're having them actively generate force into your resistance. And then you have your pure passive movement strategies. This is when you're just manually loading the system passively with your massage, foam rolling, flossing type strategies, cupping, all passive movement strategies. You might not even call them movement strategies, passive loading strategies. Okay, it's important to note that now because we want to be again clear on what interventions we're actually using, and we're going to show you again, like I said, more targeted interventions. So finally into the cases. Again, I just wanted to give you those kind of conceptual things, and of course we've kind of brushed over them quite quickly, but it is important to understand that so that you can have more clarity in why you're doing what you're doing. That for me is one of the most important things. You want to be clear on why you are doing what you're doing. So firstly, you set clear goals. You set clear goals from having clear inputs from the assessment. You can't set clear goals when you're looking for random things that can't really be observed. You can't really observe fascia. It's very messy when we look at stability, motor control, activation patterns, muscle timing, for example. Those are all very messy things. So for me, we shouldn't really be creating goals to achieve something that we struggled to assess in the first place. Because how then can you come back and say, okay, that changed? How can you say if something changed if you couldn't even assess it clearly in the first place? It's very hard to do that. So that's why we like to keep things simple again with looking at range of motion and force production. So again, looking at 4 goals here. We have, and this is case number 1, remember, with a limited lumbar flexion range of motion and some other limitations. We wanted to increase lumbar flexion range of motion and posterior pelvic tilt range of motion. But again, we wanted to consider that again, there were some limitations and some pain around the hip with that. So we don't necessarily want to just force the individual into that direction. We want to try and think about, okay, gradually exposing them to that. And really the difference here is that when there is pain associated with something, essentially what we need to do is, like I said, do a little bit, see how they feel. Feels okay? Okay, let's do a little bit more. We're just making sure we're not flaring them up. But eventually we may want them to feel better. But if we're chasing capacity, we're not constantly looking for them to feel better. For example, we're not stopping an activity if they don't feel better. We're educating them on the understanding that, okay, it's okay if this doesn't feel better because we've identified that that thing is actually limited. So I think that if we get that to improve, we can have an impact on the movement options available at your hip. We wanted to increase hip internal rotation, which again was painful and limited. So again, expanding that was very different. Increase hip extensor force production, increase quad force production. And we'll go straight into the strategies here. This was one that included all goals. So when you set goals, for example, the goals dictate what strategies you utilize. But when you're using strategies, you can use strategies that kind of tick a couple of those different boxes. You can use a strategy that ticks all those 4 boxes. You can use a strategy that ticks just one of those goals. But you need to be clear on that because what goal you're trying to influence will dictate how you progress that exercise strategy. Because if you're trying to achieve increased range of motion, you would progress that exercise strategy much differently than if you were trying to progress strength or force production. I'll kind of highlight what I mean here in just a second. This one here is one of my go-tos for trying to create lumbar flexion range of motion, particularly when there has been, an obvious weakness across the lower limb. So I like to get clients into this seated position. And essentially what I'm using here is this is what we would characterize as a coordinative range of motion strategy, where I'm trying to get some flexion into the lumbar spine, but then I'm simultaneously trying to shift stress into the legs. Okay, I find this to be something that not a lot of people do because a lot of people are focused on trying to just get range into the lumbar spine. Nobody thinks about, okay, if the lumbar spine is experiencing a lot of muscular tension, muscular stiffening, And maybe I'm thinking about my lumbar spine an awful lot. Well, one of the ways that I can add another layer to shifting activity and strain off the lumbar spine is by shifting it into the limbs. Okay, steer it into the limbs as I simultaneously get that length there. Okay, I'm not saying that you just go in and do leg extensions, leg curls, and by doing that, you get the lumbar spine to free up. The key thing here is that you have to do them simultaneously. You have to simultaneously try and get the lumbar spine to flex and get load into the lower limbs. So you're trying to change the habit. There's kind of psychological influences here, and there's mechanical influences here, of course, as well. Having a squat rack in front allows us to grab onto that squat rack. And what you saw there at the beginning was I'm posteriorly shifting my whole spine. So I'm translating my spine backwards. That allows me to get flexion into the spine initially without having to bend forward. Because oftentimes when you have clients trying to increase flexion, you'll have them bend forward and they just dump into a lot of anterior pelvic tilt. But translating the spine posteriorly allows you to get some initial spinal flexion without having to round forward. So you can see I already have some spinal flexion there. I haven't even rounded forward yet. We can encourage some posterior pelvic tilt there. And then I'll try to hold on to that posterior pelvic tilt as I round forward. And of course, not every client's going to be able to get into this position initially, but we can work with what they have available. And then I'm trying to maintain that with that forward shin angle, and I'm hovering my pelvis off the, my glutes off the chair here, and I'm holding that isometrically, but I'm keeping that reach forward. You can imagine, because the thigh bone connects the hip bone to the knee bone, when you drive the knees forward, that's going to pull on the lower pelvis even more. So if you were to try this at home, and sometimes I'll have clients use their sink, I'll have clients use the door knobs on a door, or door handles on a door, set a seat up in front of that and use that to assist them to drive backwards to the spine. But when you try to consciously reach the knees forward, you'll get the quads working a lot more, but you'll also have to drive a lot more of that lumbar flexion. And so we'll load that isometrically there and hold for time. Again, when we're dealing with pain, we'll do a little bit, 10, 15 seconds, stand up, we'll reassess what was limited and painful, or again, we'll have a baseline of something to retest against to make sure that we are not flaring them up. This would be a hip internal rotation strategy. I like personally, when I'm working with clients, particularly with hip issues, I will keep the downside elbow on the ground. I won't prop someone up onto their hand, because all that would be doing is, if I try and prop my trunk up into an upright position, all that's doing is it's driving hip abduction. That's all it's doing, because it's going to require the pelvis to come down over that right leg, and it's just going to challenge hip abduction. If I'm not trying to improve hip abduction, then why am I trying to bring the trunk up into an upright position? This is like your classic in a 90-90 positions, but clients struggle to get into those positions because they're actually driving it into hip abduction, which we don't necessarily want. So what's important here is that we keep the downside elbow on the ground. So we keep that kind of femur more kind of in the sagittal plane at the beginning here. And then what I like to do is I like to slowly build tension into the ground. One of the things that you're going to see here is that when clients build pressure into the ground via the inside of the foot, the glutes will clench and stiffen. That's one of the difficult things about this, is that and one of the important things I think is that it allows clients to really get that load into the deep hip rotators. Okay, you're essentially trying to externally rotate, okay, the hip here from an internally rotated position. Okay, so you're loading the external rotators in a lengthened position here. Okay, but we don't want the big glute max and the superficial glute max to just clench. We want to try and keep that relaxed. And one of the ways that you do that is by slowly building pressure down to the ground. And then we can just rotate the pelvis to that same side, to the right side in this case. That's going to get the pelvis to rotate to the right in this case. It's going to leave the femur rotated to the left, which creates that internal rotation. And we repeat the process again. Okay. Now, that was painful for the case number one. So we couldn't do that. We tried it. Client could not tolerate it. So what we tried to do there then was just continue with other strategies to progress towards getting length, or to progress getting load into the glutes and getting that posterior rotation of the pelvis. And we progress then to that. So you can think of this was kind of the session number 1, session number 2 strategies, not reflective of everything. This is what we progress to then. So what we progress to from this strategy here, again, like I said, it's not reflective of everything, is just into a split squat position. And we, again, use the same idea here, just simply moving from a double leg strategy into a single leg strategy, getting more load into the quads and hovering the knee, but still trying to get that lumbar flexion range of motion to get load into the glutes, load into the quads, okay? Now, the key thing to understand here is that when we are getting load into the quads and the glutes simultaneously, we're not really loading any one in isolation. This is why we would call this more of a coordinated force production strategy, because we're getting load into the quads and load into the glutes. If we wanted to constrain that demand into the quads, we may bring the individual up into an upright position. We might try to elevate the heel a little bit there as well, but we're trying to get both to work here. But key focus on keeping that lumbar flexed position. And then we progress into this local range of motion strategy. Okay, that allowed us to hit a lot of things. It allowed us to hit lumbar flexion range of motion, hip extensor force production, quad force production, and then what we eventually did with this client was progressed into more local strategies to isolate load into the hip extensors and quads. Initially, we wanted to get a sharing of load between them both. Okay, using more coordinated options first, then progressing into more of a local strategy. So once we worked on this, getting that pelvis to posterior rotate, then the individual could tolerate this position and this strategy. That allowed them to tolerate that then, okay? And then we progressed into more of a kind of a glute biased split squat where we have the wall in front. And having the wall in front here essentially allows us to drive force down and back into the ground so we can propel our bodies up and forward towards the wall. So we get a bit more of a hip extension moment. Okay, instead of going straight up and vertical, up and down, that will get a bit more of a distribution of load between the glutes and the quads. So changing the direction of force from straight down to down and back. Because again, I don't want to get too deep into the biomechanics here, but when you drive down and back, the ground reaction force, which is the force that acts back on your body when you push into the ground, will move in this direction here, which will run more parallel to the shin, which will run through the knee joints, and reduce the moment arm of the knee extensors. Compared to if I push straight down, now the force vector goes through this, in this direction, straight up, and now I have a moment arm available. Again, this is just basic biomechanics, okay? So, still repeating the same thing, trying to get into that lumbar flex position, driving down and back. And so, what I'm doing here is I'm almost trying to I'm driving down and back with the intention of going up and towards the wall, and then I can start to pulse. So I'll do a lot of pulses in the mid-range here, okay? And then I can progress to a bigger range of motion. We can add some extra demand through the forefoot, not with the intention of getting more load into the calves, but what that heel lift will do here is it will actually shift the force vector even further forward, which will actually, if you watch the cursor here, that will actually increase the hip extensor moment arm. So a lot of people will lift the heel to try and get the calves to work, but by lifting the heel, you'll actually get the glutes to work harder as well, because you change the entry point of the force vector. The key thing there is not just going up and down, you'll see how I'm projecting my body up and forward, and then I'll go through a bigger range of motion now. So those are some key strategies and progression pathways for case number 1. You'll see there that a lot of focus was placed on getting that lumbar flexion range of motion. And so we wanted to include that. So you'll see that there was a lot of goals included into each strategy here. But that's important to do because you're not necessarily going to have just one exercise for that goal, one exercise for this goal. Because when you're loading the glutes, you're challenging a lot of different things. But if you're not clear about why you're doing it, then what ends up happening is that a lot of these exercises become disconnected. And when you're progressing things, so for example, if I wanted to progress hip flexion range of motion, what I would simply do here is I would just get deeper. So if I wanted less hip flexion here, for example, I would just build up blocks underneath my knee. So I'm coming out of hip flexion. Now, if I wanted to progress range of motion, I would go deeper into hip flexion. I might bring this knee down. I might stack some blocks underneath the front foot here to get into more hip flexion. If I'm working for more range of motion. Now, if I am working towards increased force production, I'm probably going to stick around the mid-range here, and I'm going to overload that with, again, mid-range movements, adding some external loads and pulses in the mid-range. Okay, I'm not going to try to expand the range of motion. Okay, so really important to consider that there. Case number 2, remember, was struggling to actually get hip flexion, was struggling to rotate the pelvis forward. So we wanted to try and challenge that. Also a limitation in hip internal rotation as well. We wanted to increase hip extensor force production and hip adductor force production as well, because this client had some groin pain, some sensitivity through the anterior medial hip. And I'll show you one of the ways that I find works great to reduce that sensitivity, even with your osteitis pubis sensitivity through the front of the pelvis as well. Because a lot of the times, a lot of the exercise strategies for the adductors is actually in a shortened position. When you're in a Copenhagen plank, number one, you're not just getting load through the adductors, you're getting load through the lateral abdominal wall as well. So you can't hold that for long durations. That's one of the big problems there. So let's show you the hip flexion strategy first. And this one actually was too painful for the client to do initially. Okay, so remember, this client had a CAM surgery. So a lot of sensitivity around the labrum. So this would be a local. So when you see the what this says here, this is how we document it. So L, range of motion, means a local range of motion strategy, means that we're trying to constrain range of motion into the hip compared to a coordinated force production strategy, which you'll see in a second, where we're not just trying to constrain load into the hip, we're trying to get some load range of motion into the hip, but spread that demand into the quads. So it gives them the opportunity to spread demand. That's what we had to do initially, then come back to this as they increased tolerance. But because there was sensitivity around the hip joint, when we used a local range of motion strategy, and that's constraining demand, constraining range of motion into the hip joint, it was just too sensitive. So we had to respect that, back off, but that gives me information. That helps me understand that, okay, you can't do that. It doesn't mean that's a bad exercise. It just means that I want to work towards your ability to do that. I want to build your tolerance to be able to do that thing, okay? So we looked at this already. This is what it looks like from the side. So we're getting into this quadruped position. This right hip would be the target side. What we'll do initially, can I show you a different sequence there? Oh, no, I'll show you this. So I'm externally rotating the femur here. So you can imagine what happens at the greater trochanter there. When I externally rotate this right femur, the greater trochanter will drop down, expose the lateral tissues. If you were to internally rotate this right femur here and then try to shift laterally, you're not going to get very far because everything here is just going to bunch up even more so. Okay, you have to actually externally rotate the femur, drop the greater trochanter, and afford space for you to laterally translate into. Okay, and then we're essentially going to drive the pelvis laterally, which you saw in the previous video. And then what we can do is we can add, what I like to do is I like to add a light contraction into the ground. That's why I like to have a rolled up yoga mat there, because I like to gently crush the knee into the ground to get some low load into the hip extensors. It looks very easy, but you will feel a really constrained contraction into the hip extensors here. And then we can progress by going back further. We can progress the lateral translation like we saw in the other video there, okay? If, for example, they feel some sensitivity into the hip, they might have gone back too far. What I also like to do here is I like to elevate. So you'll see a step here. I like to elevate or it could even be books at home for the client. You elevate the hands onto something in front. You essentially bring the trunk up into a less horizontal angle. And then naturally, you're actually reducing hip flexion there. So if someone says, oh, I have a pinch in my groin there with that, they're just in too much hip flexion, okay, that they can tolerate. But we knew that this individual needed hip flexion. So we didn't want to just try and not do it. Well, we eventually had to do something else. But we wanted to tweak and modify it first. But again, we have to respect that if they can't tolerate it, I'm not going to be comfortable giving the client this exercise going home with because they're likely going to flare themselves up at home. Okay. So we're driving that down there. But like I said, by elevating the hands onto something in front, we lift the chest, we lift the trunk, we reduce hip flexion via the trunk. So what we ended up doing initially here was more of a coordinative range of motion strategy. What that means is that we're including multiple joints. So I'm in a split stance position, a split squat position here, but I have something in front here to lean into, so I can reduce the overall demand on the hip extensors. So I can lean my trunk into the chair here. But what this allows me to do is it allows me to hinge forward through whatever motion I have available, keep the knee or the shin more or less vertical, and I'm hovering the rear knee up off the ground. I'm driving straight down, slightly back, just to get some light load into the glutes in a lengthened position. That for me would be, again, you can say it's a blend between a force production and a range of motion strategy, but because I'm being very mindful as to the position of the hip and what I'm working towards, I'm looking at it as more of a range of motion strategy to get that pelvis to rotate over the femur. What I'll often do here as well is I will actually drive the pelvis laterally here. So I'll push the right pocket to the right here to get a bit more length through the hip here. So I don't mind if the client feels a bit of quad. I don't mind if the client just feels a bit of glute. I'm trying to work towards this here. And so kind of one of the reasons we kind of created, I suppose you can say, these progressions is when you think of it from a psychological standpoint. If someone's been avoiding something for a long period of time, or if you're scared of something, do I just throw you into that thing with no other options? Right? I have to give you the opportunity to, if you're scared of spiders and I put you into a room with spiders and I lock the door, that's not going to be a good starting point. But if I unlock the door and I give you the opportunity to get out of the room if you get really scared, then that's a good thing. So what I'm doing here is essentially giving the nervous system the opportunity to say, hey, if those glutes really struggle, if I struggle to handle load around the hip, I've got the quad there. The quad is there for you to get some load into if you need it. But the progression from that then would be to come back to this. So if I'm scared of spiders, I eventually want to be comfortable in a room with a locked door. Again, stupid example, in a room full of spiders, right? I want to really allow my system to tolerate that. So again, the psychological kind of features here and mechanical features. Some other strategies that we use, again, because if you can't anteriorly tilt the pelvis, right? What can you not lengthen? You cannot lengthen your posterior lateral hip. So the seated figure 4 stretch for this client, or movement, was really limited in this client. So a side plank variation that I really like to use, particularly when clients are, they have kind of pinchy anterior hips, is I like to get the individual into a side plank position, but with the hips flexed at around 45 degrees. So not to 90 degrees. You can go to 60 degrees. You can modify the hip flexion angle. But from there, I like to rotate. Again, I'm exaggerating it here, of course, but I'm rotating the trunk, I'm driving the femur over the top of that knee to basically bring the pelvis over top that downside femur. That gets me length through the posterior lateral hip, but I'm driving load into hip abduction here via the driving of the knee into the ground. And then I'm keeping that rotation of the trunk towards the ground. I'm keeping that reach forward. I can get a bit of help from my top hand here. And a key thing to understand here is that when you lift that top leg, that's going to put a lot more demand on the downside hip. A lot of clients will say, I don't feel my hip working that hard. And the top knee is resting on the downside knee. You have to lift that top knee off to actually put demand on the bottom hip. Okay. And when you do that, they say, oh, I feel it straight away. Okay. So really important, because sometimes clients will just keep their knees together. But you can rest the foot on the other foot as well. You keep that gentle knee reach, and then you can work into some kind of short range pulses here. But you'll really feel a nice length and load through the posterior lateral hip here in a non-provocative way, but in a way where we're getting that pelvic rotation over top the femur, and we're helping to expand that hip internal rotation there via a different kind of method there. Because again, generally here, we were actually able to restore that hip internal rotation without using a femoral dominant strategy. because we just allow for general length into the glutes via this strategy here, and this strategy here allowed us to achieve that length. And just jumping into the, I know we're kind of up on an hour and a half here, so I apologize to you. I kind of put too much into the webinar, but look, more information is always good. This strategy here is one that I will use when individuals have, a painful kind of squeeze test in supine, hips flexed, knee flexed. You squeeze the knees, they say ouch into the medial hip, into the groin. One of the simplest things you can do to desensitize the groins there is to load the adductors in a lengthened position or a mid-range position. I love to use a Swiss ball or a stability ball for this. Okay, so a nice big stability ball. Again, sometimes I'll have to even let clients bend forward and use their elbows with a joined hand so they can push into their elbows. But here, what you're doing is you are allowing the knees to come wide, and the surface of the stability ball makes it much easier to kind of crush the knees into the stability ball. And it allows you, here's the key thing, it allows you to generate a low intensity contraction for very long durations. So I'll even hold this for up to 90 seconds to 2 minutes with clients in the kind of a more of a, I wouldn't say it's a lengthened bias there, but more of a mid-range position, because even in your Copenhagen plank positions, when the femur is at the side and you've got your trunk parallel to the femur, it's in a shortened position. And so if everything's bunched up into the anterior pelvis and hip, I don't want to load it there. I want to just get some length there. But again, this also takes away the demand of the lateral abdominals, the obliques, during a Copenhagen plank as well. But you will feel a really nice kind of constrained demand into the upper groins with this one as well. And we can manipulate the pelvic position as well, add more or less anterior pelvic tilt there too. And then of course, we just progressed into this quadruped variation here. So try this, couldn't do it. Worked on these ones here with some other kind of strategies. We're not showing everything here, of course, but these are the big things, the big rocks that move this client forward. And then we progress back into that then later in the rehab process, including these strategies here, all to try and increase the length and load through the posterior lateral hip, increase the load tolerance of the adductors. We can, of course, progress into more challenging strategies in there, and then, of course, increase hip flexion. As we're progressing here, lastly, just to show you kind of a couple of different variations here. And I'm going to start I'm going to skip this one here, but I'm going to jump into this, this knee dominant strategy. This would be more of a local force production strategy to, again, constrain demand into the hip extensors. Because when we're doing it on the knees, we're taking away the contribution from the quads, from the knee extensors. So what we're doing here, I'll kind of fast forward the video for a second here. So I'm driving the hips back. I can plantar flex the ankles if I need to, if I'm kicking into the ground, for example. But what I'm doing is I'm translating my pelvis laterally, and I'm driving force down into the yoga mat with the knee. But you will feel a very strong isolated contraction into the hip extensors here without demand from anything else. That's the benefit here, is you are giving nothing else the opportunity to contribute to the contraction. You're constraining the demand to the hip extensors. Okay, that's why you're on the knees. That's why we have a bit of support in front, because if the support was not in front, the lumbar extensors will contribute an awful lot. Okay, so it's more of a kind of a concentric dominant strategy. I'll show you what it actually looks like from behind here. It's a little bit easier for you to see. So we're shifting back, driving the pelvis laterally. That allows me to get load over the right knee. Let's say that's the target side. Keep that lateral translation. We get length and load here. We drive the knee down. We hold that there. We're offloading this side, the left side, and we are experiencing that demand through the right hip extensor here, the hip extensors. And then we can add some dynamic motion there as well as a progression. Lastly here, just to finish up, I want to show you kind of two different positions that are a bit more kind of a bit more pelvic biased. So some of the hip extensor strategies that you've seen there are more femoral biased, where the femur is the thing that's driving the contraction, right? But we can also challenge the hip extensors via the pelvis. Now that's via the trunk as well, because the trunk moving forward will ultimately try to pull the pelvis into further anterior tilt. And that's going to put demand onto the hip extensors. I like to use a door frame setup here. I use a door frame setup like this an awful lot, mainly because it allows me to stabilize the position of the pelvis. It allows me to bring my other leg here into a backward position. And that actually facilitates this hip flexion via the pelvis. So it allows me to it makes it easier for me to rotate that pelvis forward, get that load into the hip extensors, and then we can experience that load, hold isometrically, and go dynamically through the range of motion as well. Okay, but the key thing there is that you're getting pure rotation of the pelvis. You're getting this motion here. You're not getting any translation of the pelvis. Okay, and again, you can bring the arms in front to get even more demand, because what that's doing there is it is increasing the moment arm of the hip and lumbar extensors, because more mass is being pulled in front of you. There's more demand on the muscles that stop you from falling forward. And these are just ones that you can work towards in these cases, particularly case number 2, where the individual was struggling to get that motion of the pelvis over top the femur. Last one here, and then we'll answer some questions, is this knee blocked hinge. So I just want you to see the difference here between this one and the door frame blocked position. In this position here, and you'll see kind of in just a moment, with that knee blocked in front via the Pilates block, yoga block here, I'm leaning into that as well. What's happening is I'm able to actually posteriorly translate my pelvis with an anterior tilt. But as I get through a bigger range of motion here, what you'll see, it's towards the end, what you'll see is I'm able to get a little bit more translation. So that allows me to actually drive my pelvis forward and back. So you see the difference there is that it's affording me the opportunity to not just rotate my pelvis, but to translate my pelvis back and forth. So you get a lot more demand through the glutes there as you couple that rotation and tilting of the pelvis with a translation of the pelvis. Okay. So again, importance, you might say, okay, do I really need to know this? I think it is important, because you will have situations where individuals will be avoiding that, particularly individuals with a history of surgery in those areas. They'll do whatever they can to avoid loading those tissues. And I think a part of our job is to gradually expose the individual to those positions, to those contractions, to build tolerance. And that's where I see biomechanics becoming really important, because it allows us to understand that. It informs us as to how we might go about organizing the system to do that. Okay. So finished up there. I know we went over. Apologies. It always happens. I'll just jump into the questions there, Kyle, if that's okay. So first question here, do you use lumbar force production strategies in a lengthened position as well? So yes, I would. If, for example, this individual was dealing with, or as an additional kind of later stage rehab strategies, if I wanted to say, okay, well, let's actually really push that lumbar spine a bit more here. But because the focus is the hip, I don't want to kind of throw too many things at different structures. I'm essentially trying to get range of motion at the spine, lumbar spine, and then use that to influence the hip. But the key thing to understand there is that if I just jump back here for a second, with, and it actually just doesn't show this here, right? But if in this position here, right, if that wall was not in front, essentially what that wall is doing in front as well, not just the stability, is it's reducing the extension demand on my spinal extensors, because I can lean into the wall, right? If I was to take my hands away from the wall, then what's going to happen is gravity is going to try to pull my spine into flexion, which means that you're getting a contraction demand into the lumbar extensors. So that is actually what we progress to with this client. So we're just essentially progressing from a supported split squat to an unsupported split squat. Because with an unsupported split squat, where I'm out in open space, I'm actually getting what you're saying there. I'm getting hip extensor loading. I'm getting lumbar extensor loading. Now, there are ways where I can, you can get into like your good morning strategies with more of a flexion bias, your Jefferson curl type strategies as well. But again, that's a way for us to hit a couple of those things without saying, okay, I need to isolate that demand into those tissues. Other question as well, in the quadruped position for femoral flexion range of motion, do you sometimes add femoral internal rotation as well? In that quadruped position, I wouldn't necessarily add internal rotation to that, largely because it just doesn't feel good for a lot of clients when you're going back into hip flexion. So imagine like you were doing this yourself. If you were to kind of flex your hip in standing, you internally rotate, and then you try to flex even more so. It's not going to feel that good on the hip because you're not allowing for the lateral tissues of the hip to lengthen. Now, I'm not saying you can't do it, but if the goal is to get length into the posterior lateral hip, you have to consider, well, what direction does the femur need to move in to get length into the piriformis, for example, beyond 90 degrees? It needs to externally rotate, right? Because above 90 degrees, the piriformis becomes an internal rotator. So you need to externally rotate as you go beyond 90 degrees to get that length into the piriformis. And if you internally rotate, you're just going to reduce that lengthening demand. But the key thing there is that if you were to internally rotate, if you even try it now, you bunch up the lateral tissues and it just makes it harder for you to get that length as you laterally translate. By externally rotating the femur, you drop the graded trochanter, you expose the lateral hip to more length, and then by laterally translating, you'll experience that stretch much sooner in that range. And it's just a bit more comfortable. But you can certainly do some kind of general kind of internal, external rotation movement strategies there. As like a general kind of movement prep type thing to just get some general motion in those directions. I like to kind of use that strategy there also as a way to kind of ramp up the contraction intensity as well. So I will also use this setup here to kind of really ramp up. So think of the kind of a kneeling variation that we did on the step. If I go back kind of quite far into the hip extension here, number one, I'm taking away lumbar extensor demand because I have my hands on the ground. But I can really have clients ramp up that contraction into the ground, or that driving of the knee into the ground here, to really load the hip extensors. It's one of the best ways to really sense that load into the hip extensors at length. And you can imagine if the hip was internally rotated, you just wouldn't be able to go. You're kind of moving into a W sit then, right? Like that W sit position where feet go out, knees go in. A lot of clients can't get into that position, right? It doesn't mean you shouldn't do that. It doesn't mean it's bad. It's just a question of kind of why you're doing it. The reason we have this femur and external rotation is to expose length posteriorly and laterally. That's the key thing there, to expose not just sagittal plane, transverse plane, but also frontal plane length into those tissues. Okay. Thank you for those questions. I know I went on. No problem. Happy to help. So hopefully, guys, that made sense there. Again, I tried to include as much conceptual things because if we didn't go through a lot of this conceptual stuff early on, sometimes it just doesn't make sense why we're organizing the cases in this way. Because again, like I said, it starts with clear goals, an understanding of what's available, what's unavailable, what's painful, what's non-painful. And then understanding, well, how am I organizing the rehab process then to expose what's unavailable? If I'm trying to expose something that's unavailable and painful, then that's a slightly different process to exposing and expanding something that is unavailable and non-painful. That's why I really like to kind of map things out and classify things like this. And if you're to look at my documentation, I don't color things in red, orange, and green. This is just for you to see. But it allows me to just step back and see, okay, what is available here? Because sometimes when you look at documentation, and I do, of course, measure, again, how much range was there. I measure, okay, or I document how much range of motion. Was it 100 degrees and so on and so forth? But sometimes when you see all those numbers and you're just trying to get a big picture, it's hard to kind of look at the big picture when you're looking at lots of numbers. If you have a way to classify it using this system here, it just allows you to say, okay, what might I want to work on here? And then we can go deeper to say, okay, well, what about that was unavailable? But just allows you to get an insight into how the system is being organized. Okay. So we'll finish up there, Kyle. I think, sorry
Yeah, that's
for going
perfect.
over.
I texted, I messaged in the chat. Recording will be sent out this evening. So like I said at the beginning, just check your spam for it. Sometimes they go there, but that recording will be available for the next 30 days. So take your time to watch it, reference it back, and hopefully everyone learned something today.
Perfect. And guys, remember, if this information resonated with you at all, we have next cohort coming February 27th. Sign up opens February 9th. These are the modules. Again, if you kind of would like to dive deeper into this information, then definitely would recommend jumping on here. We can have some good discussions and go through this stuff in much more detail. But like Kyle said, hopefully you enjoy the recording. And for those of you that lasted all this time, thanks so much. And hopefully you enjoy the rest of your evening.